Good day everyone. For this Hematology 2 seminar, we will be tackling the peripheral blood smear and the blood cell normal and its anomalies. For our objectives, we should be able to recall the significance of the peripheral blood smear in determining blood cells, discuss and explain various blood cell abnormalities that are used in identifying blood cell disorders, and to associate different blood cell abnormalities with their corresponding diseases. So without further ado, we'll start now with your peripheral blood smear. The peripheral blood smear, or simply PBS, is a manual and convenient procedure used to examine the blood cells of a patient. Now, the wedge film preparation is the most commonly used technique in making peripheral blood films. This technique requires at least 2 clean glass slides. One slide serves as your blood film and the other as your pusher or spreader slide. A drop of EDTA-treated blood, about 3 mm in diameter, is placed at one end of the slide. Alternatively, a similar sized drop of blood directly from a finger or heel puncture is also acceptable. Note that the size of the drop of blood is important. A drop that is too large creates a long or thick film, and a too small drop often makes a short or thin film. In preparing the film, the medtech should hold the pusher slide securely in front of the drop of blood at a 30 to 45 degree angle to the film slide. For higher than normal hematocrit, the angle between the slides must be lowered so that the film is not too short and thick. For extremely low levels of hematocrit, the angle must be raised. A well-made peripheral blood film has the following characteristics. 1. About 2/3 to 3/4 of the length of the slide should be covered by the film. 2. Slightly rounded at the feather edge or thin portion and should not be really bullet-shaped. 3. Lateral edges of the film should be visible. 4. It should have smooth without irregularities, holes, or streaks. 5. When the slide is held up to the light, the feather edge of the film should have a rainbow appearance. So kapag tinutok siya sa ilaw, kailangan parang nagre-rainbow yung reflection ng inyong smear. And lastly, number 6, the whole drop that was placed at the side of your slide should be picked up properly and spread evenly. The purpose of staining blood films is to identify cells and recognize morphology easily through the microscope. Your right or right Giemsa stains are the most commonly used for PBS and bone marrow films. These stains contain both eosin and methylene blue, thus termed as polychrome stains. The colors vary slightly from laboratory to laboratory depending on the method of staining. Slides must be allowed to dry thoroughly before staining. The cells are fixed to the glass slide by the methanol in the stain. Staining reactions are pH dependent, and the actual staining of the cellular components occurs when a buffer, pH 6.4, is added to the stain. Free methylene blue is basic, thus it stains its opposite components, which are the acidic cellular components such as your RNA, into color blue. Free eosin is acidic, thus stains its opposite component, which are the basic cellular components such as your hemoglobin, into color red. An optimally stained film has the following characteristics. The RBCs should be pink to salmon, the nuclei are dark blue to purple, and the cytoplasmic granules of the following should be: your neutrophils are lavender to light black, your basophils are dark blue to black, and eosinophilic granules should be red to orange. And lastly, the area between the cells should be colorless, clean, and free of precipitated stain. Best staining results are obtained from freshly made slides that have been prepared within 2 to 3 hours of blood collection. Basically, in APBS, we would be able to see the normal and abnormal cells of the patient. The RBC, WBC differential, platelet morphology evaluation, and platelet estimates are performed under the oil immersion objective or OIO. The RBC and WBC inclusions can also be observed in this magnification. Evaluation of morphology is an important aspect of the film evaluation and is used in conjunction with the indices to describe cells as normal or abnormal in size, shape, and color. So in this discussion, since Hema 2 tayo, so I'll be focusing now on the anomalies rather than the normal cells. Okay, so let's start off with the platelet anomalies and disorders. Your platelet disorders is divided into two anomalies. You have your vascular abnormalities and your platelet anomalies. Under your vascular abnormalities are the following, while under your platelet anomalies are these of the following. Now, these vascular and platelet anomalies can be observed in the different platelet disorders, such as your hemorrhagic platelet disorders, your qualitative platelet disorders, and your quantitative platelet disorders. We would be briefly discussing these one by one. Let's start off with your vascular abnormalities, starting off with your petechia. Your petechia are pinpoint hemorrhages which represent blood that has leaked out from intact capillaries. This is due to a increased vascular permeability or failure of platelet function. So, among the vascular abnormalities, si petechia yung pinaka-maliit. We also have your purpura, which describes the appearance of confluent patches of petechia. This is due to bleeding in the lower surface or bottom of the skin. And we also have your ecchymosis, which is commonly known as bruises or sa Tagalog, yung mga pasa. And this represents a larger amount of extravasated blood under the skin. When we say extravasated blood, ito yung mga lumabas na dugo sa balat na natin. Okay, doon na siya sa surface ng ating balat. Kaya nagkakaroon ng pasa or bruises. We also have your hematoma, which are large ecchymosis because it already involves subcutaneous tissue or muscle producing localized swelling and deformity. So, kung sa ecchymosis, yung blood lang yung nag-seep out dun sa surface ng skin nyo. Sa hematoma, affected na yung tissue and also the muscle na malapit dun sa affected area. And we also have your hemarthrosis, which describes a hemorrhage into a joint. Now, the following are the platelet disorders that are related to vascular abnormalities. We have your ITP, which is a immunologically mediated platelet disorder, specifically by IgG, where it usually occurs after a viral infection. Examples of viral infection are your measles, rubella, and chickenpox. We also have your hemorrhagic telangiectasia, which is also known as your Osler-Weber-Rondeau syndrome, which is a hereditary vascular disorder. There is the presence of your telangiectasia or your visceral lesions. We also have your Ehlers-Danlos syndrome, wherein there is collagen insufficiency, leading to joint and dermal hypermobility. We also have your Henoch-Schönlein purpura, which is also known as your allergic purpura or IgA vasculitis. This is triggered by allergic reactions specifically mediated by your immunoglobulin A. You also have your scurvy, which is also known as your vitamin C deficiency, which produces ecchymosis and red papules joined together. And lastly, we have your Kasabach-Merritt syndrome, which is also known as your congenital hemangiomata, wherein there's the presence of your visceral tumors. Specifically, your Kaposiform hemangioendothelioma and your tufted angioma. So, do not forget, kapag sinabi nating hemorrhagic telangiectasia, visceral lesions, and kapag sinabi nating Casa-Bach-Merritt syndrome, ang associated ay visceral tumors. Under your platelet anomalies, we have the first one, which is your platelet clumping. The platelet clumping may be due to the following. First is due to slow venipuncture or a true and true venipuncture. So, meaning to say, yung sa vein nyo, lumagpas yung pagkatusok nyo, tas lumabas yung mga dugo. That triggers the clumping of your platelets, which may be present in your PBS. It may also be due to a EDTA-induced treatment in your blood and also may be due to a aged blood sample. So, meaning, more than 24 hours nang nakolek or nakastand yung blood nyo. And then, upon checking under the PBS, there might be a presence of your platelet clumping. You also have your platelet satellitosis. This is the phenomenon of the adherence of platelets to your WBC. Examples are this one. This may be an in vitro phenomenon of no clinical significance unless it may be associated with the disorder of the patient. Next, we have your platelet thread, which are activated platelets that look like a spider-like or thread-like projections present in your blood smear. And lastly, we also have your giant platelets. Your giant platelets may indicate a premature release from the bone marrow due to increased demand. And these platelets are usually bigger than your normal RBCs. Now, the platelet disorders that are associated to platelet anomalies are as follows. You have your Glanzmann thrombasthenia, which is there's the absence of your glycoprotein 2B and 3A, which leads to a aggregation defect. We also have your Bernard-Solier syndrome or your BSS, wherein there's the absence of your glycoprotein 1B, which is the receptor of your von Willebrand factor. And this leads to a adhesion defect. We also have your pseudothrombocytopenia, which is there is a decreased number of platelet due to the presence of your giant platelets being counted as a RBC or WBC cell. And we have your giant platelet syndrome. The next slide shows to you the disorders associated to the different coagulation factors. So, starting from factor 1 until factor 13, nakalist lahat ng names nila, their synonyms, and their active forms. And also kung saan pathway sila nag-participate. The C stands for common, the E for extrinsic, and then I for intrinsic. And then on the last column, you would be able to see the associated disorders per factors. Although may ibang factors na wala namang associated na disorders. Kindly please remember this kasi minsan lumalabas sila sa board exams din. Aside from the other platelet anomalies mentioned a while ago, let's also discuss thrombosis and DIC. When we say thrombosis, this is an inappropriate formation of platelets or fibrin clots that obstruct the blood vessels. This often leads to deep vein thrombosis and also the presence of embolus. We also have your disseminated intravascular coagulation or simply DIC. This is also known as your defibrillation syndrome, your Truchus syndrome, and your consumption coagulopathy. This is a generalized activation of the hemostasis, wherein a fibrin microthrombi partially occlude small blood vessels and consume your platelets, coagulation factors, and fibrinolytic enzymes. And take note guys, si DIC, never siyang magiging primary disease. Your DIC would only be a secondary disorder to a systemic or primary disease of your patient. And lastly, we have your quantitative platelet disorders. Under these, we have your thrombocytosis, which is the increase in the circulating platelets, and your thrombocytopenia, which is the decrease in the number of platelets. On your thrombocytosis, the associated disorders may be due to reactive thrombocytosis or myeloproliferative disorders. When we say reactive thrombocytosis, nagkakaroon lang siya ng increase in the number of platelets due to its primary conditions, such as when the patient has blood loss or underwent a surgery and splenectomy, or when the patient has IDA or under a stress or strenuous exercise. Another condition that is associated with the increased number of platelets are the myeloproliferative disorders, and these are your polycythemia vera, your CML or your chronic myelogenous leukemia, and your myelofibrosis with myeloid metaplasia, and lastly your essential thrombocythemia. We also have the term thrombocytopathy, wherein it means there is a change in the platelet function. Now, the disorders associated with platelet aggregation and platelet adhesion, as mentioned a while ago, pag sinabi natin Glanzmann thrombasthenia, it's a platelet aggregation defect. And kapag sinabi natin Bernard-Sallier syndrome, it's a platelet adhesion defect. Lastly, we also have your disorders of platelet secretion, and the associated conditions with this one are your storage pool diseases. We have your alpha granule deficiency, which is the gray platelet syndrome, and kapag ang deficient naman ay sa dense granules, these are the following. We have your Hermansky-Pudlak syndrome, your Shiajaki-Higashi syndrome, and your Wiskott-Aldrich syndrome. Let's proceed now to red cell anomalies and their associated disorders. Now, to summarize your anemia, it is divided according to increased RBC loss and decreased production. Anemia due to increased RBC loss is divided according to hemorrhagic and hemolytic anemia, which is further divided according to intrinsic hemolytic anemia and extrinsic hemolytic anemia. On the other hand, anemia due to decreased production is divided according to its MCV values. You have your normocytic, your microcytic, and your macrocytic. Let's proceed now with the first term, which is anisocytosis. Anisocytosis is the increased number of red cells with variation in size. Usually, your anisocytosis is divided according to its MCV values. Thus, we have your normocytes, your microcytes, and your macrocytes. Normocytes is usually known also as discocyte. Its size is the same as the lymphocyte's nucleus, with a size of 6 to 8 micrometers in diameter, and its MCV values is within 80 to 100 femtoliters. Next, we have your microcytes. From the name itself, these are smaller than the normal RBCs that we have. Thus, it has a diameter of less than 6.0 micrometers and an MCV value of less than 80 femtoliters. Usually, microcytes are associated with abnormal hemoglobin formation. Lastly, we have your macrocytes. From the name itself again, macrocytes are larger compared to your normal RBCs. Thus, its diameter is more than 8.0 micrometers, and its MCV value is more than 100 femtoliters. Macrocytes are usually associated with impaired DNA synthesis. Now, your anisocytosis can also be detected in the machine using your RDW values. Your RDW stands for red cell distribution width. Now, take note that RDW values has a reference range within 11.5 to 14.5%. Now, take note when your RDW has a normal value, but the patient has decreased MCV, the patient may have ACD, or anemia of chronic disease. Now, when the patient has a normal RDW and also normal MCV, the patient may have G6PD deficiency. Or when the patient has normal RDW but with increased MCV, the patient may have liver disease. Now, on the other hand, if the patient has increased RDW with decreased MCV, the patient may have IDA. When RDW is increased but with normal MCV, it may be associated with sickle cell anemia. And lastly, if the RDW of the patient is increased and also with increased MCV value, the patient may be associated to have megaloblastic anemia. Normally, RBCs have a central area of pallor approximately 1/3 of its diameter. Now, once your red cells have a variation in its normal coloration, the term that we use is called your anisochromia. Again, anisochromia is the term used for variation in the normal coloration. This is the occurrence of your hypochromic and normochromic cells in the same blood smear and usually associated with the following conditions. You have your sideroblastic anemia, hypochromic anemia after transfusion with normal cells, and weeks after a patient with IDE undergoes iron therapy. Now, we call the cells as hypochromic when the central pallor usually takes up more than 1/3 of its diameter, and it's usually microcytic at the same time. We have a special RBC cell called as annulocyte, which is also known as your pessary cell or ghost cell. Your annulocytes are special RBCs with a thin rim of hemoglobin, thus associated with low MCH value, and a large clear center associated with severe anemia caused by impaired hemoglobin synthesis in iron deficiency. So, usually, ganito yung itsura niya. Or, mas manipis pa dito. Usually, ganyan na lang siya talaga. For the grading of hypochromia, kindly please remember 1+, 2+, 3+, and 4+. Para matandaan nyo yung grading ng hypochromia, tatandaan nyo, ganito nyo siya i-drawing. 1, 2, 3, 4. When we say 1+, it covers 1/2 of the diameter of the cell. 2+ kapag 2/3 na yung cover niya. And then 3+ kapag 3/4 na yung cover ng cell. And then 4+ kapag thin rim na yung hemoglobin na present sa red cell niya. Okay? We can also term a cell as hyperchromic when it lacks a central pallor even though they lie in the desirable area of your blood smear. This may be caused by a shape change. Now, your hyperchromic cells may be a true hyperchromia if also your MCHC is high. So remember, you can only associate hyperchromia with a disorder if your MCHC is also high. And the only disease in which your MCHC is high above the reference range is your HS or your hereditary spherocytosis. Next term we have is your poikilocytosis. This is used to denote the increased number of red cells with variation in shape. And the following are the different poikilocytoses that we are going to discuss one by one. Spherocytes, from the name itself, they are spherical in shape, and compared to a normal RBC, they do lack the central pallor due to a protein defect. Now, the associated conditions to spherocytes are, of course, your hereditary spherocytosis. It may also be seen with patients suffering from severe burns. Usually, microspherocytes yung nakikita nyo dito. Aside from that, it can also be seen with conditions of transfused cells. And lastly, your ABO, hereditary disease of the newborn. Your HDN is a red cell disorder where the maternal natural occurring IgG antibodies pass through the placenta to the fetal circulation, where they can cause hemolysis of the fetal red blood cells, which leads to fetal anemia. Usually, your mother is blood type O, and then the baby would either be blood type A or B. Tapos, di ba, si mother's antibodies, which are anti-A and anti-B, i-attack niya to si baby, causing now the hemolysis. Stomatocytes is also known as your mouth cell. These are elongated RBCs with a slit-like pallor and usually considered as an artifact unless it would be related to the diagnosis of the patient. So, ikaw, as a medtech, you have to check the patient's diagnosis first before considering this as an RBC anomaly. Your stomatocytes are associated with the following conditions. First, your hereditary stomatocytosis, electrolyte imbalance or dehydration, your Rh-null syndrome or phenotype, alcoholism, and severe liver diseases. You also have your serocytes. Your serocytes are the dehydrated form of the stomatocyte and are described as half dark and half light cells. This form of stomatocyte is seen in DHS or the dehydrated hereditary stomatocytosis or hereditary serocytosis. Your hereditary serocytosis is the most common form of stomatocytosis. Acanthocytes is also known as your thorn cell and spur cell. They are so called as such because of their irregular spicules and their shape. So remember, irregular acantho, irregular acantho. The associated conditions are your abetalipoproteinemia, which is also known as your hereditary acanthocytosis. You also have your McLeod syndrome, which is associated with your KEL antigens, your PK or pyruvate kinase deficiency, your vitamin E deficiency, malabsorption, and hypothyroidism. So please remember the RBC anomalies associated to blood groups. Kapag associated sa ABO, HDN, spherocyte. Kapag Rh-null syndrome or phenotype, stomatocyte. And kapag KEL blood groups or McLeod syndrome, it is associated with acanthocyte. Echinocytes are also known as crenated RBCs. These are RBCs with regular spicules around its edges. It is usually considered as an artifact, but relevant in certain conditions such as your bile acid abnormalities or the use of drugs and chemicals such as your barbiturates and salicylates. Your Burr cell is also known as your sea urchin cell, and these are characterized as RBCs with regular pointed spicules. It may also be considered as an artifact, but when considered as an anomaly, it is associated with the following conditions. You have your uremia, which is associated with end-stage renal failure, acute blood loss, and pyruvate kinase deficiency. So, tatandaan yung mga RBC anomalies na may spicules. You have your acanthocyte, echinocyte, and Burr cell. Acanthocyte, irregular spicules. Echinocytes, regular rounded spicules. And Burr cells, regular pointed spicules. And what are the RBC anomalies associated with pyruvate kinase deficiency? Your acanthocytes and Burr cells. Next, we have your ovalocyte and your elliptocyte. When we say ovalocyte, these are oval-shaped or egg-shaped RBCs. On the other hand, your elliptocyte are usually described as a cigar-shaped RBCs. And these two are usually associated with hereditary elliptocytosis or ovalocytosis, IDA or iron deficiency anemia, megaloblastic anemias usually seen as a macroovalocytes, and also with myelocytic anemias. The cryocyte is a pear-shaped or teardrop-shaped RBCs, hence also known as your teardrop cells. It is associated with the conditions pernicious anemia, primary myelofibrosis, and myelocytic anemias. Your primary myelofibrosis is also known as your myelofibrosis with myeloid metaplasia. Tatandaan, M. Next, we have your schistocyte, which is also known as your schizocytes or helmet cells due to their shapes. Now, these cells looks like fragments of RBCs and are often associated with the following conditions. Patients with artificial heart valves, your microangiopathic hemolytic anemia, uremia, and your disseminated intravascular coagulation. And again, this is a condition wherein there is a overactivation of the coagulation and your fibrinolytic system. Now, your bite cells and blister cells is also associated with your schistocytes. These two are the result of the splenic pitting of your hinds bodies, which are often included under this category. As mentioned previously, your bite cell may be classified under the schistocyte category, but can be described separately. So your bite cell is also known as your drepanocyte, keratocyte, or degmacyte. They demonstrate a semicircular defect in their edge, which resembles a bite mark. The associated condition with bite cell is, of course, your G6PD deficiency. So, tatandaan, the RBC anomalies associated with uremia are your Burr cell and your schistocytes. Next, we have your drepanocyte, which is more commonly known as your sickle cell and meningocyte. It has two forms. You have your irreversible sickle cell and your oat-shaped cell. Pag sinabi nating irreversible sickle cell, when reoxygenated, they stay as a crescent-shaped RBC with long projections. Okay? So, kahit nabigyan na siya ng oxygen, ganito pa din yung itsura niya. Pero kapag sinabi nating oat-shaped cell, once reoxygenated, they return to their biconcave shape. Hindi talaga yung normal na shape ng RBC, pero usually nagiging mukha na siyang oats. Ganito siya, yan. Mga ganyan. Kaya eto. No? So, there will be less pronounced projections. Now, the associated conditions under this anomaly are your, of course, sickle cell anemia, your homozygous hemoglobin S disease, and your hemoglobin SC disease. Now, among the RBC anomalies, your leptocyte has the anomaly with many other names. You have your target cell, your codocyte, your platycyte, your Mexican hat cell, Greek helmet cell, and bullseye cell. All of which because sa kanyang itsura. Okay? Mukha daw siyang target, tsaka bullseye cell. Tapos, mukha siyang plato daw. Ayan, kaya siya platycyte. And then, mukha din daw siyang Mexican hat cell kapag tinignan mo on top yung hat. Ayan. And then, for the Greek helmet cell, I really don't know why, pero baka na-imagine nila to. Baka din pag tinignan on top yung helmet na to, mukha siyang target cell. Okay? Ayan. Now, your leptocyte or RBCs, which shows a centrally stained area with a thin rim or outer rim of hemoglobin. Now, the associated conditions with leptocyte is your hemoglobinopathies, obstructive liver disease, your thalassemia, and your LCAT deficiency. Your LCAT stands for lecithin cholesterol acyl transferase, whereas your thalassemia is also known as your hereditary leptocytosis. Let's also go over with some of the inclusions present in RBCs. First off, we have your Howell-Jolly bodies. Your Howell-Jolly bodies contains your DNA or your deoxyribonucleic acid and usually present in singles or maybe in multiples. Pero mas common yung single lang siya dun sa loob ng RBCs nyo. And the associated conditions with this one are splenectomy, hyposplenism, megaloblastic anemia, and hemolytic anemia. Next inclusion that we have are your basophilic stippling. Now, your basophilic stippling is usually seen in numerous with fairly even distribution. And the composition of your basophilic stippling are your RNA or your ribonucleic acid. And the associated conditions with basophilic stippling are usually lead intoxication, thalassemia, and abnormal heme synthesis. Next inclusion that we have are your Pappenheimer bodies. These are siderotic granules, often seen as a color light blue with fine, irregular granules in clusters. Usually, they may be seen as multiples clustered in one place, often at the periphery of the cell or dun sa mga edges. Okay, and the composition of this inclusion is iron. And the associated condition with Pappenheimer bodies are splenectomy, hemolytic anemia, sideroblastic anemia, megaloblastic anemia, and hemoglobinopathies. So, tatandaan, kapag ang inclusion ay Howell-Jolly bodies, it contains DNA. Kapag naman basophilic stippling, it contains your RNA. And kapag naman Pappenheimer bodies, it contains your iron. Last inclusion in RBCs are your Cabot rings. They are usually dark blue to purple that looks like a loop, ring, or a figure of 8 that may look like beads on a string. Usually ganito. Yung 8, ganito yung itsura niya. Okay? They are usually present to 1 to 2 per RBCs, and their composition, they are believed to be remnants of a mitotic spindle. Now, the associated conditions with Cabot rings are your myelodysplastic syndrome and megaloblastic anemia. And with that ends our discussion for Hematology 2 seminar, specifically peripheral blood smear, the normal and abnormal blood cells. Thank you for listening.